everyone, myself Dr. Malika, DNB Family Medicine resident. Today I will be talking about the management of the myocardial infarction. When patient come with the chest pain, like severe cardiac chest pain, the pain may be either centralized left side or epigastric. The pain will be radiating to the neck, arm, sometimes it will radiate as high as up to occipital region. The pain will be accompanied by the weakness, sweating, nausea, vomiting and anxiety. After diagnosing the patient is having myocardial infarction, how we should treat that patient? Coming to the treatment, we have to check the airway breathing circulation. If the patient's saturation is less than 90, we have to apply the face mask and or nasal plugs and maintain the saturation above 90%. We have to maintain the saturation above 90% with oxygen of about 4 liters per minute. Then we have to decrease the thrombosis by giving the aspirin and clopidogrel. Aspirin dose should be given about 325 mg stat and clopidogrel 75 mg stat. We can give 300 mg stat also. And lipid lowering agents like atorvastatin and rosuvastatin. It should be given if the patient come within the 24 hours. Atorvastatin should be given dose of about 80 mg. Both this is the antiplatelet and this is the lipid lowering agents. Both antiplatelet and lipid lowering agent will decrease the mortality rate of the patient. So now we have to control the chest discomfort of the patient by giving these 3 drugs like sublingual nitrate should be given first by of about 0.4 mg stat. If it is not decreased, we can give up to maximum 3 doses with a 5-minute interval. If the patient is having the low systolic blood pressure and bradycardia, we should avoid giving nitrate. If the patient was on phosphodiesterase 5 inhibitor in last 24 hours, even in this patient we have to avoid the nitrate. If the patient is not getting relief with the sublingual nitrate, we have to go for the nitrate infusions. Even if the patient is not getting relief with that, then we have to go for the morphine, which is the effective analgesic. It may cause a vagotonic effect. It will lead to the bradycardia and sometimes advanced degree of heart block. In bradycardia, we have to treat the patient with the atropine of about 4.5 mg IV. Morphine should be given in the dose of 2 to 4 mg. Next, we have to give the beta blockers, IV beta blockers. The dose generally, metoprolol is the most common beta blockers which we use in this condition of about 5 mg. Total 3 doses can be given of maximum of 15 mg. We should maintain the 2 to 5 minutes gap in between. If the patient is having the hypotension or the bradycardia, in those conditions we have to avoid the beta blockers. After giving all this, we have to decide the patient should be reperfused either by the PCI, that is percutaneous coronary intervention, or the thrombolysis. If the hospital is having the cath lab, then we can go for the percutaneous coronary intervention. If the hospital is not having that facility, we have to go for thrombolysis. That means the patient should be thrombolized within 30 minutes of presentation. We can be thrombolyze the patient with using the IV streptokinase or altipase or the TTPase. After the thrombolysis, we have to treat the patient with anticoagulants, that is with IV heparin. It should be given 60 to 70 units per kg. That means maximum of 5,000 units should be given stat. After that, followed by the infusion of about 16 to 17 units per kg. Then we can titrate that value. This was asked for 5 to 6 times in previous 10 years question paper. You should never neglect this question. This is very important. In coming videos, I will discuss how to diagnose the MI with some ECG pictures. Hope you like this video. Thank you.